All right. So today I'll be presenting on a study that I did with the Black and Racial Equity Research Program at the University of Calgary on access to healthcare for Black women in Canada. I know Tamar provided us with land acknowledgements already, but I would also like to share provide an acknowledgement of where I'm situated here in Edmonton. So today I am joining this call from the area now known as Edmonton, which is traditionally located or traditionally called Amiskwasi Waskahikan, located on the territory of the Cree, Blackfoot, Métis, Nakota, Dene, Iroquois, and Anishinaabe. Lands are now known as part of Treaty 6, 7, and 8 and homeland of the Métis. I respect the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit. So, as a person of African descent, West African descent specifically, I also offer this land recognition in a solidarity with the Indigenous peoples of Turtle Island in the efforts and deliberate intentions towards decolonization. I acknowledge the land of Turtle Island was never meant to be owned and recognize that this land, which has been stewarded by Indigenous peoples since time immemorial, was in some cases shared by choice, however, was most often taken by coercion or force. I recognize the historical colonialism and the ongoing colonialism that has shaped the present day, where land acknowledgements are now offered in place of land. As people of African descent, many of us have come here by choice, while many are here as a result of historical force. And so we must acknowledge the complexities of living on land that was not freely given, partitioned by those whose it was never meant to give. As a person of African descent, I acknowledge how the land of Turtle Island sustains and express deep gratitude to its indigenous people and pledge to honor the dignity and divinity that ultimately connects us all. I will continue to listen to indigenous stories, learn from indigenous ways of being, and practice solidarity that supports our survival as we work towards the disruption of oppressive structures and our collective liberation. I provided two links here um, that helped me kind of reflect on my relationship with the land. Some of you may be familiar with those links already. Um, and I modified um, Kay Johnson's Afrocentric land acknowledgements to help me reflect on um, my ongoing relationship with the land and how I can continue to support and advocate for um, land back for Indigenous peoples on Turtle Island. So before I move further on, I think it's also important to acknowledge who's all involved in this work. So Dr. Lua Bukula Salami was the PI for this project, and I've listed everyone that was involved in this work in some capacity because it would not have been possible without the contributions of all these team members. And I also want to acknowledge and thank community partners such as Black Health Alliance, the Black Opportunity Fund, and Black Women in Action for their collaboration on this important work. And of course, the work would not be possible without financial support from organizations and research institutes, such as the Women and Children's Health Research Institute at the U of A. So I think it's always important to, before doing any, engaging in any kind of scholarship, I feel it's important that we sit and introspect and reflect on our positionality within the work. So you're probably wondering, well, you're a Black woman and you're doing research with Black women. What's there to consider? What's there to think about? And I say there's a lot. So the four key members that led this work, Dr. Bukola, myself, and Dr. Karanja and Yawa Edie are all Black women. Two of us are registered nurses, and three of us are health professionals. Yawa has specialty in counseling and psychology, and Dr. Karanja has specialty in education. So while being Black women allowed us to engage with participants in, a very relational way and a very familiar way, it was also important that we didn't take our own experiences and reflect them onto the stories that participants were sharing with us. So it's sort of a double-edged sword where, yes, it helped us better understand the stories that we're hearing, but at the same time, we had to be careful not to overstep um, the boundaries between our experiences and participants' experiences as well. And so the objectives for today, which Tamar have already outlined, listed here, we'll learn about factors that hinder healthcare access for Black women, facilitate healthcare access for Black women, and some reflection on the perinatal health aspects of these factors as well. I also wanted to add this here real quick. Dr. Salami is a Canada researcher in Black and racialized people's health, and her position, the funding from this work also supported this work as well. And the work that she's doing within this research position is to advance and uplift and support the well-being of Black and racialized people in Canada, Black women included. So we know that in Canada, there's been significant growth of the Black population in the past several decades. We can go even further back and talk about immigration policies and regulations, but that's not the focus of today's discussion. So with this significant growth, there's been a push for more research on the health of Canada's growing Black population. And when we look at the statistics, we see that a majority of this growth in the past 10, 15 years has been in the prairies, in Alberta specifically. And then when we scale down and look at Alberta, we see that Black women are about 4.2 of the population of women, a population which continues to grow. With the data that does exist on the well-being of Black women in Canada, we see that there are greater reports of chronic conditions such as diabetes, hypertension, heart disease. And within this population, there's reports also of inadequate treatments. They're not receiving the same treatments as their white counterparts. I know there was a study that came out maybe 10 years ago that showed that Black women with the same symptoms of heart disease, of cardiovascular disease, tend to receive less treatment and less comprehensive treatments when they do receive treatments compared to white women. So that speaks to how the healthcare and the care of women within the healthcare system is poorly managed, and the disparities and inequities in the care of Black women. So when we look at the factors that may contribute to these inequities in healthcare access or treatment within the healthcare system, we're seeing that there's not only the matter of race, of gender and race, the discrimination is quite pervasive, and this contributes to the poor health outcomes that we're seeing for Black women in some instances as well. So, because we're looking at a study, because we're trying to understand um, health outcomes for Black women, a population that is multiply marginalized, it fit well to use intersectionality by Crenshaw to frame our thinking around this topic. So, as many of you might be familiar with intersectionality already, is the use of intersectionality in scholarship has grown exponentially in the past several decades. It's a very helpful and an analytical framework to help us understand, how various aspects of an individual's social identities shape their social location and their experiences with power, privilege, discrimination, and oppression. And for Black women, this is particularly salient when we think about Black women having poorer outcomes than the rest of the than Black population as a whole. That speaks to their experience as both Black and gendered, which shapes how they experience care, how they navigate healthcare, and then their healthcare outcomes as well. I won't go into too much detail with intersectionality, but that's, I think, overall a good framework for how we approach this work. I do also want to note, however, that when we examined the healthcare access experiences of women, this is with the acknowledgement that individual experiences or experiences at the individual level are not isolated from systemic and structural level dynamics. They're interconnected. And so that was part of our application of intersectionality as a framework as well. Hmm. So looking at the demographics of our sample was primarily a younger sample. Most participants were, I guess, the biggest age range was under 30. Most participants were born in Canada, had been in Canada for over 10 years, um, very well off in terms of education and social economic status. And I think a part of this was because we did use snowball sampling in our recruitment. And so that kind of shapes the demographic characteristics of the sample as well. So speaking more specifically to factors we found that hinder healthcare access for Black women. So at the individual and interpersonal level, we found that factors such as patient-provider discordance directly impacted how women accessed or experienced healthcare. For one, the language of the participants. If they didn't speak English at home as their primary language, that made it sometimes difficult to then go to a provider who only spoke English and maybe didn't have access to translation services. And on a related note, there were cultural differences as well. I know one participant spoke to, going to the doctor and describing something a certain way that would make sense to um, a family member or someone in your culture, but a white doctor didn't understand what they were saying and so dismissed them during that encounter. Gender as well. And these sort of discordance and other factors led to negative encounters when accessing healthcare. Participants felt dehumanized, dismissed. Racism was a consistent lived experience for participants as well. And all these factors and experiences together often led to a distrust or mistrust in accessing care. I won't go over the quotes. I thought I would have more time, but I'm either talking too slow right now or my slides are too much. Um, and so, on an institutional and systemic level, participants shared socioeconomic barriers, health system issues, and also talked about racism. And racism was a whole section on the institutional and systemic level because there's so many different forms of racism and it's so pervasive when accessing healthcare. And so participants talked about, the subtle comments that providers would have, overt discrimination, and things built into the system that limited or that served as barriers to their ability to access care. On the other side, there were a number of factors that also facilitated healthcare access. So, on the individual interpersonal level, you have the concordance of the patients and provider, and then the individual and social network strengths, such as advocacy for self and others, health literacy, social network supports. And we found that these facilitators not only were provided improved healthcare access for the woman, but also extended into those within your networks as well. And then on the institutional systemic level, um, things like community and social services, coverage from work benefits and insurance, having access to a family physician, proximity, more streamlined processes and virtual services improved Black women's ability to access care. And so from this work, we put together um, a policy brief to the Standing Committee on Health. And we outlined a few recommendations to help support and improve the health of Black women and improve their perinatal health outcomes, especially in terms of breast cancer, ovarian cancer, cervical cancer outcomes. There was a call to develop a national Black health strategy, which included collaborating with Black communities to form more comprehensive strategies for improving Black women's health. We called for more increased funding for research on Black women's health, such as to the National Women's Health Research Initiative. We called for more race concordance care to increasing the representation of Black healthcare providers at all levels to promote better care and increase trust, decrease distrust, decrease mistrust, and towards improving the outcomes of Black women in the community. And of course, this also includes race and ethnicity disaggregated data collection. Anyone who's done or interacted with any health research in Canada in the past decades has identified or acknowledged this significant gap in the body of research and how we collect research. And of course, the type of data that we have affects the type of outcomes that we have and affects the type of interventions that we're able to provide for communities. And then lastly, mandating greater research accountability through greater consideration of race and racism, EDI, despite the current social political climate, it's calling for EDI in the the process of doing research just past the grant proposal stage. And of course, including an intersectional lens in doing research, because this allows us to address the multifaceted aspects of Black women's experiences. Thank you.
Thank you so much, Mary. We're now going to hand it over to Dr. Peter.
Hi. Okay, brilliant. Sorry about that. Hi, everyone. So I also cannot see you, so I hope that my slides are going to advance properly. Hi, everyone. My name is Michelle. I'm a social scientist, and I'm a research fellow based at Great Ormond Street Hospital and University College London in England. And I spend a lot of my time speaking to parents about their experiences of maternity care. And I also speak to a lot of healthcare professionals too about what it's like to deliver that care to families. But my main interest is in the experiences of families who are from Black and I guess what we would call over here in the UK, racially minoritized backgrounds. And so I've worked on kind of lots of projects that have had that focus. And from everything that Mary's saying, it just resonates so completely with the context here in the UK as well, which is, I guess, really awful to see. But for anyone, I guess, who works in this field, when you speak to Black parents about their maternity experiences, it's almost impossible really to disentangle racial inequities from the experiences that they have. And so over here, there's been a lot of attention on maternal health inequality. There's been a lot of attention worldwide, right? But it's in the UK here, it's a big focal point. In fact, even today was the release of a national maternal and neonatal inquiry that was ordered and commissioned by the government over here. And the interim findings are not completely unsurprising. There are many drivers of inequalities, as Mary so nicely laid out. But how someone has been socially racialized is a strong predictor of their maternal outcomes, definitely here in the UK. And really what I'm interested in is trying to better understand, I guess, what it is about parents, what it is about clinicians, what it is about the system that they are working in that gives rise to some of those inequities. And I'm going to keep kind of championing Mary because she so beautifully described that interplay between individual and structural factors that give rise to these inequities. And that's what I'm going to talk to you a little bit about today, about how they have shown up in my current work, which is my fellowship project looking at Black women's experiences of prenatal testing. So this is not an exhaustive list of factors that have come up in my work, but it's the key ones that keep coming up. And so what I'm going to talk to you about today is not just about Black women's experiences, and this is an interview study that I did with 39 Black women in England, but also healthcare professionals too. So this is healthcare professionals working in fetal medicine, in who are genetic counselors, who are midwives. And I'm going to talk about both because I think you can't have one experience without the other and without understanding that context. So I thought it would be helpful to understand how prenatal testing works in England, because I imagine that it probably differs across the various settings that you might work in. And so the NHS is a publicly funded health system. And I'll kind of walk you through this timeline. So maternity care in England is largely midwifery led. And women and birthing people self-refer. So when they find out they're pregnant, they choose a hospital that they want to have their baby in and they let the hospital know. And then they get given a booking appointment. And that appointment is typically with a midwife, and that's around 10 weeks, where they will discuss at that appointment things like nutrition, smoking, mental health. All of this is kind of crammed into about a 1 hour session. And in there, you also talk about screening, and that is offered to all women and birthing people. It's a very routinized process. And the typical screening that gets offered here is called the combined screening test. And that includes a blood test and an ultrasound scan. If you present later in pregnancy, you might get offered the quad screening test, or if they can't quite get the measurements that they need to on the scan, you might be offered the quad screening test. And then, sorry, I should have moved that along before. And then at 20 weeks, you get a detailed anomaly scan. And ultimately, if there is anything on the scan or anything in the screening that you've had earlier on that suggests that there might be a genetic condition or an anomaly, then you're offered further diagnostic testing. And I think what's really critical at this point to get across is that we in England have a population screening programme. So everyone is offered screening regardless of which hospital you go to or your financial situation. So these factors in and of themselves are not barriers to access. But yeah, what I'm going to describe to you is interesting because it doesn't matter, even if you can access the best hospital or you have the most money, we still see these inequities arise. So a key factor that I have identified in my work is that parents start from different points, and this is across many different dimensions. So critically, though, the inequities that we see don't arise because there are these differences, because parents have these differences, but it's because there's a failure to adapt to these differences. And one of the key differences is in knowledge and understanding about genetics, about the screening tests that are offered. And so what I found in speaking to the parents that I've spoken to is that there can be misunderstanding, for instance, about who can be carriers of genetic conditions. This quote on the left is a scenario where there was a Black woman who decided that she was going to decline screening because she had married a white man. And her view was that it's not possible that he could have sickle cell trait. And so she declined screening. She declined testing because she felt that it wasn't possible for him to have sickle cell trait because he was white. There can also be misunderstandings about how conditions are passed down through families and which conditions affect which populations. So this quote on the left is a Black African mother who I interviewed, and she said, I don't think it happens to Black people for the Down syndrome. So she didn't believe that Down syndrome could happen to Black people. And she said, it wasn't until I met someone who actually went through it and I was so shocked. Now, the consequence of I guess, these misunderstandings is that parents may decline testing. There may be undiagnosed cases, which then leads to increased complications in birth and afterwards. And also, it just doesn't give people time to prepare psychologically. And the inequity arises here because the appointments that are provided to parents are rushed. Then there's no time to explore. There's no time for parents to even get to the point where they might even be able to share with a midwife that there are these understandings about how conditions are passed down. Now, another difference that has come up a lot in my work is English language ability and whether or not parents are able to fully understand the options that they are given during their discussions about prenatal screening and testing. And amongst a lot of the healthcare professionals I've interviewed, they all see interpreters as very critical to the appointment, but lots of concerns about the sensitivity and the accuracy of the information that's being conveyed, also as well as how impartial those interpreters are being, which can be a real barrier to providing the kind of culturally safe care that we want to provide to women. So this is an example here of an interview I did with a fetal medicine consultant who described a consultation that she was having with a parent who didn't have very good English. but had enough English to be able to understand that what the interpreter on the phone was saying to her was not the same as what the clinician was saying to her. And she kind of let the fetal medicine consultant know, she's not saying the same as you. And the interpreter then put the phone down. So we see how we've got these tensions and this difficulty and challenges in trying to convey very complex information to parents who don't have English as their first language. And the inequity that arises here is that they are denied that same level of reproductive autonomy as English-speaking patients. Now, another difference in starting points is in the level of trust. And again, Mary's already kind of covered this. And this can be in community narratives. And this has come up so much in the conversations that I've had with Black women, is these kind of, I guess, stories that have been passed down through families. And this is an example from an interview that I did with a mother who talked about how, she said, my grandma said I'm going to be used as a guinea pig because she has her own perception of the hospitals, things that were done in the 1980s. That's why I chose not to have the test. And this parent had declined an invasive test on the basis of her grandma's experiences. And similarly, people's kind of just personal views around what these tests are doing, how accurate these tests are. This is an interview that I conducted with a woman who talked about, what the test algorithms are. What are they based on? If it's based on a white person and you're a Black person, that doesn't make sense at all. And so these conversations were so common, these worries about ulterior motives or how they themselves as Black women would be perceived by healthcare professionals who might not share or understand their culture. And so the inequity is, if you don't have trust, then you're less likely to accept medical recommendations, including prenatal screening, which, if they are not, I guess, trusting of these tests, they might decline them. And then conditions that could be managed before or immediately after birth go undiagnosed and lead to kind of these poor perinatal outcomes that we see. And so I want to kind of segue. I probably don't have a lot of time, but I really want to segue into this thing about mistrust.
You still have some time.
Do I?
Yeah.
Okay, sorry, I'm speaking really fast. We in the UK, we talk a lot about trust, and this lack of trust in certain communities. And I'm getting quite agitated by it because my sense is that people have become quite desensitized to what that even means. It in the circles that I'm in, I feel like the word is used quite casually now, it almost in like a pejorative way that puts the responsibility of being trusting onto communities, onto people that have absolutely no reason to be trusting, while simultaneously removing the responsibility of organizations to demonstrate their trustworthiness. So I've started now, like in lots of the talks I'm giving, to be very open. But if we're going to talk about trust and lack of trust, then we need to understand the source of mistrust. And I would strongly imagine that many people do not really understand where this comes from. And obviously a key contributor is the historical and obviously ongoing discrimination and unequal treatment and medical exploitation of Black people, especially historically enslaved people who were used as a commodity of medicine. And so I have just put some of these examples up here that I'm sure this audience, probably far different to the UK audiences, because these are a lot in the kind of US context, examples that kind of highlight this exploitation. And I'm not going to go through all of them, but we've got the Tuskegee syphilis study. We've got James Sims, who performed gynecological procedures with no anesthesia on enslaved women. And we've got Henrietta Lacks, who during her treatment for cancer had her cancerous cells stolen. And like I said, a lot of this is situated in the US, but I do want it to be clear that Britain played a very huge role in this abuse of medicine in the context of slavery. And we have British doctors who, John Quire, I think, for one of them, who worked in rural Jamaica and who experimented with smallpox inoculation. So this is where it comes from. And I don't think people recognize where it comes from and why, for instance, it then has consequences today. And this legacy of all of this exploitation and this harm has led to, for instance, to lots of, I guess, rhetoric and real experiences of vaccine hesitancy, particularly with the COVID-19 vaccine, with the MMR vaccine, so measles, mumps, and rubella vaccine, and that is relevant to things like prenatal testing, because people decline testing out of fear of hidden agendas, because they think results are going to be used against them, because they don't feel safe or respected. Now, another factor kind of contributing to these inequities, and I'm kind of moving away from parents and the differences in their starting points to thinking more about clinicians and their variation in clinical knowledge and their understanding of genetics themselves as clinicians. And I've just become absolutely like incensed and quite shocked that screening is not mandatory in midwifery training. So student midwives do not necessarily have to have their screening, like they don't have to have that signed off. And this obviously was quite shocking to lots of other clinicians that I spoke to. So this is an example from a genetic counsellor interview where they describe how student midwives who they felt were doing a 3-year degree would know all about first trimester screening, but at the end of it, they found out that they didn't really know much about it at all. And an area where this is particularly important is in the context of sickle cell. And there's a lack of understanding, huge lack of understanding about sickle cell amongst clinicians in the UK anyway. This is an example here of a midwife that I interviewed where she described how a parent who had sickle cell trait and was advocating and really wanting to have diagnostic testing, saying to the midwife, this is my genotype, and the midwife not even understanding what that meant. And so the inequity here is that sickle cell is highly prevalent in African and Caribbean populations, but Black people are missing out on being offered screening or being offered diagnostic testing because of lack of understanding and knowledge of clinicians. They're having results not explained accurately because of lack of understanding of clinicians, and often having to advocate at what's already a very stressful and vulnerable time for them. And what's mad to me is that sickle cell is one of the most common genetic conditions in the UK, yet it's one of the most poorly understood, which is for me like an example, a clear example of medical racism. And I'm going to segue again into other examples that we have in the UK of medical racism in maternity care that significantly impact Black and racially minoritized families. So for when newborns are checked and they have their newborn health check, they use the APGAR score. And the A in the APGAR acronym, if you don't know, is based on appearance. And these gradings are based on babies with pale skin. And they're subjective assessments that often means that it results in lower scores, basically, for Black and brown infants because the gradings and the assessments and the scale that they're using is not based on Black and brown skin. Similarly, in the education around neonatal jaundice detection, that's also based on babies with pale skin. So the education that clinicians are being given, they're undertaking, is not tailored to babies with darker skin tones. So as well as kind of variation in what clinicians are being taught about genetics, there's also variation in their comfort or more likely discomfort in talking about things like race, about culture, about religion. And there's often, what I've come across is that amongst certain clinicians, this fear of saying the wrong thing. And so they opt for a standardized approach because they're worried that they might come across as being racist, as in this example here from a genetic counsellor who I interviewed who said, as a white British female, I might think, is it okay to wonder whether there could be something cultural going on? Might this be judged by somebody? I don't want to come across as being racist. And so there's this clear kind of push to try and treat everyone the same, as if this is fairness, but we know that sameness is not the same as equity. And so what we're finding in this work is that there are some clinicians who are not able to draw on that professional curiosity that you need to have to explore what people's decision making is, but to do it in a kind of culturally safe way. These inequities also arise out of some of the assumptions that healthcare professionals might make about patients and also about their colleagues, actually. And we see kind of assumptions about who will or won't want testing based purely on the religion that certain people ascribe to. So this midwife talking about the fact that, amongst her peers, she said, we've got all of these assumptions, oh, well, she's Muslim, so therefore she can't have an abortion. And similarly, racialized assumptions about who will or won't need screening based on what they look like. And this midwife described how she said, the doctors, they look at me and because I've got light skin, they just assume that I'm not completely Black, which means I'm not going to be affected by sickle cell or anything. And so these assumptions about, what people look like, how they sound, like what their accent is, what their background is, influences how information is conveyed or even whether it's offered in the first place. And another way that they arise is in the attitudes from some healthcare professionals. And my work, I think, has really highlighted examples of quite paternalistic and steering behavior, specifically, again, in the context of sickle cell, where parents are kind of made to feel guilty or testing is framed as a moral responsibility. And these are two, I won't read both of the quotes out, but just the key points, which is parents being made to feel bad. So one parent said, you want to bring a sick baby into this world. Another parent being told by a clinician to think about the trauma of living with a child with sickle cell and the cost on the NHS of having a child with sickle cell. And so lots of this kind of fear-based messaging where testing is not really presented as a choice, which is what it should be, but it's kind of framed as necessary to prevent kind of personal and economical burden. And the inequity here, obviously, is that these interactions disproportionately are experienced by people from Black and racially minoritized backgrounds where sickle cell is more prevalent. I don't think I have a lot of time left, so I'm going to just whiz through, but I was going to link that to kind of more kind of historical views of forced sterilization and reproductive justice, and how this view of reproduction in Black women is kind of more highly policed, but you can make those links yourself. And then finally, kind of moving along this continuum away from individual behavior, but more thinking about the system, as Mary described earlier, like how do systemic and structural factors contribute to inequities? And what I found is that even when healthcare professionals are really like doing their utmost best to provide equitable care, the system within they are operating just doesn't allow it. So there are constraints on time, as I described to you before, that booking appointment, that the first appointment that women and birthing people attend is so compressed. There's so many things to cover, and as this midwife says, she said, the struggle is midwives don't have time. You've got this tick box. Did you do this? Did you do that? And when you have a tick box approach, you don't get to personalize things. And so the inequity arises when you have those who do need more time, who might speak another language, who do have concerns and are mistrustful, or who have cultural beliefs that need to be explored. There is no time to go through those things. And even when you have clinicians who might not know much about genetics, like I described earlier, you then don't even have the protected time to upskill yourself and learn about genetics. Because as this midwife said, you're already exhausted by the time you leave to go home. You're not going to go home onto e-learning and learn about genetics. It's a lot of work. And finally, it's not just about the wider system, but also about the specific organization. And in England, we have I guess, hospitals that are kind of broken up into regions and by trusts. And so there are some areas and pockets of like really good practice, but this is not consistent, essentially. And so there are differences that have come up in my work on organizations and departments where you can talk about race and you can talk about inequity, and that can be discussed quite openly and in a supportive environment. But there are also ones where people have quite a narrow understanding or acceptance of racism, as described by this midwife here, who says, they think when you talk about racism, it means the KKK. And I say to them, it's more subtle than that. It's every day. So people kind of only equating racism with very extreme or overt violent acts. And then sometimes that response to racism is indirect. Sometimes it's disengagement. It's things like people rolling their eyes during mandatory cultural competency training. It's people kind of thinking you're being aggressive or thinking you're being feisty or you're being a troublemaker because you're passionate about trying to provide equitable care and make that difference, but you're just seen as just causing a problem. And similarly, what we see is a lot of this rerouting of equity-oriented work to particular individuals. So people who have a shared culture or who have a shared language with those parents kind of being relied upon to care for those parents, because the idea of providing culturally sensitive care is not embedded in the system. And what happens is that disproportionately falls to staff from racially minoritized backgrounds often, which is hard to sustain. It's very challenging. And also it leads to inequity for parents because they are subject to variable experiences of support, because it really depends on who they're going to get on that day, whether that person that they're going to see is able to provide culturally sensitive care and operate with cultural humility. So all of these factors contribute to racial health inequities. There are so many more things I could say, but I'm going to stop here. And thank you all for listening. Thank you to all of the charities and the Black-led organisations who worked so closely with me and were amazing supporters of this work, to the NHS Trust that supported with recruitment and was super enthusiastic about this project, and also, of course, to my funders. So thank you, and thank you all for listening. And I will stop sharing now.
All
I
right.
can remember how. Stop.
Okay. So thank you once again to Mary, and thank you, Michelle. It was Interesting, but not surprising to see that although you both conduct your work in two separate countries, there's a lot of overlap and intersecting themes between both of your work. So I'm going to stop the recording now, and I will open up the floor to any questions or discussions.